At our hearing last Thursday, I said that all roads back to work and back to school run through testing, and that what our country has done so far on testing is impressive, but not nearly enough. Over the weekend, Senator Schumer, the Democratic leader, was nice enough to put out a tweet quoting half of what I said. He left out the other half, the impressive part. So let me say again what I meant by that. When I said impressive, I meant that according to the Johns Hopkins University study, the United States has tested over 9 million Americans for COVID-19. That's twice as many as any other country. We don't know what China has done. And it's more per capita than most countries, including South Korea, which many members of our committee had cited as an example of a country that had tested well. According to Dr. Deborah Birx, the United States will double testing in the month of May, which should get us up to about 10 million department. The governor's slogan is, if in doubt, get a test. Governor Lee sent his testing goals in May to the federal government, as every state has done. Federal government is helping him make sure that he has enough supplies in case he has trouble getting them through the labs and the other commercial sources. As a result, our state has tested about 4% of the population. The governor hopes to increase that by 7% in May. That's one of the best in the country. This impressive level of testing is sufficient, we believe, to begin phase one of going back to work. But as I said last week, it's not nearly enough to provide confidence to 31,000 students and faculty members who we hope will show up at the University of Tennessee campus in August when school starts. Last week, I talked with UT Knoxville Chancellor Dondi Plowman about that. We said, what would persuade those 31,000 students, as well as the 50 million K through 12 students in the country and the other 5,000 university students, what will persuade them to go back to campus in August? That's where the new Shark Tank comes in. Dr. Collins at the National Institutes of Health calls it RADx. We had our hearing about that on Thursday. It's a really remarkable scientific exercise to take a few early stage concepts that are swimming around in what we call that competitive Shark Tank and see if Dr. Collins and his associates can find a few like the ones used for flu or strep throat, which involves the swabbing of a nose, and you can get the result in just a few minutes. Another proposal, not yet approved, is to put in your mouth a sort of lollipop sponge. Take a photo of that with your cell phone and send that to your doctor. If it lights up, you're positive. Or the university might send that saliva lollipop to a nearby laboratory, which could be a gene sequencing laboratory, which can deal with thousands of those samples overnight. That same process could occur at a middle school. It could occur at a factory. Of course, anyone testing negative one day can test positive the next, but such widespread screening of entire campuses, schools, or places of work will help identify those who are sick, trace down those who are exposed, and that in turn should help persuade the rest of us to go back to school and back to work. In addition to more testing, I expect Dr. Fauci to talk to us about additional treatments that will be available to reduce the risk of death, and the administration's plan to do something that our country has never done before, which is to start manufacturing a vaccine before it actually has been proven to work in order to speed up the result in case it does work. Those vaccines, those treatments are the ultimate solution. But until we have them, all roads back to work and school go through testing. The more tests we conduct, the better we can identify those who are sick and exposed. Then we can quarantine the sick and exposed instead of trying to quarantine the whole country. Now, in my opinion, this will require millions of new tests, many from new technologies. Some of these will fail, but we only need a few successes to get where we want to go. That's why I said on Thursday that what our country had done so far in testing is impressive, but not nearly enough. First, squeeze all the tests we can out of current technologies. Next, try to find new technologies to help us contain the disease and persuade us to go back to work. Now, one other thing. This is a bipartisan hearing to examine how well we're preparing to go safely back to work and to school, and to determine what else we need to do in the United States Senate. Such an exercise sometimes encourages finger pointing. Before we spend too much time finger pointing, I'd like to suggest that almost all of us, the United States and almost every country, so far as I can tell, underestimated this virus, underestimated how contagious it would be, underestimated how it can travel silently in people without symptoms to infect other people, how it can be especially deadly for certain segments of our population, the elderly, those with pre-existing conditions, minority populations. Let me go back to the March 3rd hearing that we had in our committee on coronavirus. 6 weeks after the first case was discovered in the United States, a day when only 2 deaths were recorded in this country, I read at that hearing this paragraph from the New York Times 2 days earlier on March the 1st. They reported this: much about the coronavirus remains unclear, the Times reported, and it's far from certain, this is March 3rd, March 1, that the outbreak will reach severe proportions in the United States or affect many regions at once. With its top-notch scientists, modern hospitals, and sprawling public health infrastructure, most experts agree the United States is among the countries best prepared to prevent or manage such an epidemic. That was the New York Times on March 1. A lot of effort has gone into trying to make our country well prepared. Over the last 20 years, 4 presidents, several Congresses, in response to 9/11, bird flu, Katrina, Ebola, H1N1, MERS, passed 9 major laws to try to help get this country ready for what we're going through today. These laws stood up the Strategic National Stockpile, created an Assistant Secretary for Preparedness. It created incentives for the developments of vaccines and medicines that we're using today, strengthened the Centers for Disease Control, created BARDA, thanks to the leadership of Senator Blunt and Senator Murray for 5 straight years. We've significantly increased funding for the National Institutes of Health. All this was part of a shared goal. Democrats, Republicans, 4 presidents, several Congresses, to try to get ready for what we're going through today, whether it was known like anthrax or unknown like COVID-19. But despite all that effort, even the experts underestimated COVID-19. This hearing is about how we improve our response to this virus as well as the next one. During the oversight hearing, I also intend to focus on, as I just said, the next pandemic, which we know is coming. What can we learn from this one to be ready for the next one? What can we learn from the fast tracking of vaccines and treatments that we're about to hear about that will make it even faster the next time? How can we keep hospitals and states from selling off protective equipment when their budget gets tight? How can we make sure Congress does our share of the funding responsibility? How do we provide enough extra hospital beds without canceling elective surgery, hurting other patients, and bankrupting hospitals? Whose job should it be to coordinate supply lines so that protective equipment and supplies get where they're supposed to go when they're supposed to go? What's the best way to manage the stockpile? My preacher once said, "I'm not worried about what you do on Sunday. It's the rest of the week that concerns me." I'm afraid that during the rest of the week between pandemics, we relax our focus on preparedness. We become preoccupied with other important things. Our collective memory is short. Just 3 months ago, this country was preoccupied with impeaching a president. Now that seems like ancient Roman history. Now, while this crisis has our full attention, I believe we should put into law this year whatever improvements need to be made to be well prepared for the next pandemic. If there is to be finger pointing, I hope they're pointed in that direction. We're fortunate today to have 4 distinguished witnesses who are at the heart of the response to the coronavirus. We're grateful for their service to our country. I've asked them each to summarize their remarks in 5 minutes. Then we'll have 5-minute round of questions from each senator. I've agreed we'll end our hearing about 12:30. After we have a full round of questions, every senator will have a chance to have his or her 5 minutes. Senator Murray will then have an opportunity to ask the last question or to close the hearing, and I will then close the hearing. There will be other hearings to follow this hearing, like last Thursday's hearing, and senators may submit their questions in writing within the next 10 days. Staying at home indefinitely is not the solution to this pandemic. There is not enough money available to help all those hurt by a closed economy. All roads back to work and back to school lead through testing, tracking, isolation, treatment, and vaccines. This requires widespread testing, millions more tests created mostly by new technologies to identify those who are sick and who've been exposed so they can be quarantined, and by containing the disease in this way, give the rest of America enough confidence to go back to work and school. For the near term, to help make sure those 31,000 UT students and faculty members show up in August, we need widespread testing, millions more tests created mostly by new technologies to identify those who are sick and who have been exposed so they can be quarantined. By containing the disease in this way, give the rest of America enough confidence to go back to work and back to school. Senator Murray.
Well, thank you very much, Mr. Chairman. My thoughts are with you and your team right now as you try to navigate the same challenge so many in our country are worried about. We all wish your staff member a speedy recovery. And as everyone works to take appropriate safety precautions today, I'd like to thank not only our witnesses for joining us today, but also our committee staff for working to set up a safe format for members and witnesses and the public to participate in this hearing remotely. Families across the country are counting on us for the truth about the COVID-19 pandemic, especially since it is clear they will not get it from President Trump. Truth is essential so people have the facts so they can make decisions for themselves and their families and their communities. Lives are at stake. If the president isn't telling the truth, we must, and our witnesses must, and we're counting on you today. And families need us to take this opportunity to dig into the facts about where things did go wrong so we can finally get them on track. Because the Trump administration's response to this public health emergency so far has been a disaster all on its own. Delays, missteps have put us way behind where we need to be on diagnostic tests and allowed inaccurate antibody tests to flood the market. Corruption and political interference have impeded efforts to secure desperately needed personal protective equipment and promoted dangerous, unproven treatments. And we recently learned that after experts at the Centers for Disease Control and Prevention spent weeks developing a detailed guide to help our communities understand how to safely reopen when the time comes, the Trump administration tossed it in the trash bin for being too prescriptive. But this is far from the first time this administration has silenced experts who were doing their job and putting public health first. The fact of the matter is, President Trump has been more focused on fighting against the truth than fighting this virus, and Americans have sadly paid the price. Since this committee last heard from these witnesses on March 3rd, we have seen over 900 deaths in my home state of Washington, over 80,000 deaths nationally, and the numbers continue to climb. Still, President Trump is trying to ignore the facts and ignore the experts who've been very clear we are nowhere close to where we need to be to reopen safely. My hope today is that we can cut through this and have a serious discussion about what is needed to safely open, how close we are as a country to meeting those needs, and how we actually get there. One thing that's abundantly clear, we need dramatically more testing. It is unacceptable we still don't have a national strategic plan to make sure testing is free, fast, and everywhere. That is why I fought to make sure our last COVID-19 package included an initial $25 billion testing fund and a requirement that the administration submit a plan by May 24th. And when I say a plan, I don't mean a PR plan. I mean a plan with specific timelines and numeric goals for supply and funding needs, one that actually addresses the issues we're seeing on testing capacity and distribution and disparities and building out our public health system, and makes clear to states and tribes and employers and the American people what they can expect and what the administration will do to keep Americans safe. But testing alone won't be enough to reopen our country. We still need far more personal protective equipment than has been available for our healthcare workers on the front lines. And we will need far more for other workers as we reopen. So we desperately need this administration to step up and get that equipment to states who are doing everything in their power to purchase supplies, but simply cannot get nearly enough. Because the reality is, unlike states, the federal government has the tools to actually fix the problem if only the administration would use them. And we also need that equipment to actually work and for the FDA to act promptly if it does not weeks later when people may have already been exposed. And just as importantly, we can't expect people to go back to work or to restaurants or to confidently send their kids to school if there isn't clear, detailed guidance about how to do that safely. Schools, from early childhood through college, need to know how to keep their students, their staff, and their educators safe. When should they wear masks? How do you run a school cafeteria or a school bus? And if they can't reopen classrooms, schools and families need to know we are working to ensure every student gets an education. Tools like online learning can only get us so far if we don't address the digital divide so that every student can access them. And even then, there will be learning loss that could deepen existing educational disparities among low-income students, students with disabilities, English language learners, and other vulnerable populations if we don't make sure they get equal access to resources and support. And of course, schools aren't the only workplaces we've got to be thinking about. We need to make sure that industries across the country know how to safely reopen and that people know their workplace is safe. Secretary Scalia needs to stop dragging his feet and do his job and have the Department of Labor set forward a rule that makes clear worker safety is not optional. Mr. Chairman, I hope this committee can hear about those critical issues from Secretary Scalia and Secretary DeVos, as well as other experts in the space in the days ahead. And this is especially important to protect workers and residents at our nursing homes and other congregate care facilities, where we've seen some of the most deadly outbreaks. And as the rash of outbreaks at meatpacking plants shows, this isn't just an issue for the healthcare industry, it is an issue for everyone. And just as we need a plan before we can start to reopen, we also need a plan well before we have a safe and effective vaccine to guarantee that we can quickly produce and distribute it on a global scale and make it free and available for everyone. So I'll be asking about our progress on those issues today. Today, safely reopening our country may be a ways off, and the administration's planning may be way behind. But there's still a lot that Congress needs to do. There isn't time to spare. Some, including the White House, say we've already provided enough economic relief. Well, my question to them is, what good is a bridge that only gets you to the middle of the river? We don't need to wait around to see if people need more help. We know they do. We need to work quickly on another aggressive relief package, and we need to make sure our priorities in that bill are protecting our workers, our students, and our families, and addressing this public health crisis, not bailing out corporations or protecting big business from accountability. People across the country are doing their part. They are washing their hands and wearing masks and social distancing and staying home. They need their government to do its part too. They need leadership. They need a plan. They need honesty, and they need it now before we reopen, so they can rest assured that we are doing things safely and competently with their health and well-being as a top priority. Thank you, Mr. Chairman.
up this hearing. It's an important hearing, and I know lots of people may be watching it for the first time. If they are, I hope they notice that we have 23 members of this committee, I believe, one more Republican than Democrat. We have some very strong views, but we're able to work together and to express those views and respect each other and our witnesses. And a big part of that goes to Senator Murray and her staff. So thank you for that. Each witness will have up to 5 minutes to give his testimony. Thank you for making an exception and agreeing to testify by video because of these unusual circumstances. And thank you for what you're doing for our country. Our first witness is Dr. Anthony Fauci. He's director of the National Institutes of Allergy and Infectious Diseases at the National Institutes of Health. He's held that position since 1984, which meant he's advised 6 presidents and worked on HIV, AIDS, influenza, malaria, Ebola, and other infectious diseases. He was involved in treating Ebola patients at NIH and also worked on vaccine trials for Ebola. Next, we'll hear from Dr. Robert Redfield. He's director of the U.S. Centers for Disease Control and Prevention, which has its headquarters in Atlanta. More than 30 years, he's been involved with clinical research related to chronic human viral infections and infectious diseases, especially HIV. He was the founding director of the Department of Retroviral Research within the U.S. military's HIV research program. He spent 20 years with the U.S. Army Medical Corps. Third, Admiral Brett Giroir. Admiral Giroir is Assistant Secretary for Health at the U.S. Department of Health and Human Services. That puts him in charge of development of public health policy recommendations. He's taken on the responsibility for coordinating testing and focused on the increasing number of tests that we can do with existing technology. His federal service includes a variety of activities with our Defense Department in advanced research, threat reduction. He was part of the Blue Ribbon Panel to reform the U.S. Veterans Health System. And finally, we'll hear from Dr. Stephen Hahn. He's Commissioner of the Food and Drug Administration. Before joining FDA, he was the Chief Medical Executive of the University of Texas MD Anderson Cancer Center. He was chair of the Department of Radiation Oncology at the University of Pennsylvania. He was a senior investigator at the National Institutes of Health. He was commander of the U.S. Public Health Service Commission Corps in 2025. Now we'll ask each of our witnesses to summarize their remarks in 5 minutes. Following that, each senator will have 5 minutes for questions and answers in order of seniority. Dr. Fauci, let's begin with you. Welcome.
Thank you very much, Mr. Chairman, Ranking Member Murray, and members of the committee. Thank you for giving me the opportunity to discuss with you today the role of the National Institutes of Health in research addressing COVID-19. The strategic plan that we have is fourfold. One, to improve our fundamental knowledge of the virus and the disease it causes. Next, to develop new point-of-care diagnostics. Next, to characterize and test therapeutics. And finally, to develop safe and effective vaccines. First, with regard to diagnostics, as you probably heard from Dr. Francis Collins last Thursday, the NIH has developed a rapid acceleration of diagnostics program called RADx, with an award to that specific program of up to $500 million to support the development of COVID-19 diagnostics. It is a national call for innovative technologies that will be evaluated in a Shark Tank-like selection process to get to either success or failure rapidly. Moving on to therapeutics, I'll talk a bit about the remdesivir success antiviral in a moment, but let me emphasize that there are a number of broad-spectrum antivirals that are in various stages of testing. In addition, we will be looking at convalescent plasma, which is plasma from individuals who've recovered from COVID-19, to be used in passive transfer, either in prevention or treatment. In addition, hyperimmune globulin, which can be used as a gamma globulin shot. We'll be looking at repurposed drugs, as well as immune-based therapies and host modifiers, and finally, monoclonal antibodies. Let me take a moment to describe the remdesivir placebo-controlled randomized trial, which was done internationally with a power of more than 1,000 individuals in sites throughout the world. It was in hospitalized patients with lung disease. The endpoint was primarily time to recovery. The result was statistically significant, but really modest. And we must remember, it was only a modest result, showing that the drug made a 31% faster time to recovery. We hope to build on this modest success with combinations of drugs and better drugs. Moving on to vaccines. There are at least 8 candidate COVID-19 vaccines in clinical development. The NIH has been collaborating with a number of pharmaceutical companies at various stages of development. I will describe one very briefly, which is not the only one, but one that we have been involved in heavily developing with Moderna. It's a messenger RNA platform. You might recall in this committee that in January of this year, I said that it would take about 1 year to 18 months if we were successful in developing a vaccine. The NIH trial moved very quickly. On January 10th, the sequence was known. On January the 11th, the Vaccine Research Center met to develop a plan. On the 14th of January, we officially started the vaccine development. 62 days later, we are now in phase 1 clinical trial with the 2 doses already fully enrolled. There will be animal safety. The phase 1 will directly go into phase 2-3 in late spring and early summer. And if we are successful, we hope to know that in the late fall and early winter. There are some important issues, however, in COVID-19 vaccine development. We have many candidates and hope to have multiple winners. In other words, it's multiple shots on goal. This will be important because this will be good for global availability if we have more than one successful candidate. We also, as the chairman mentioned, will be producing vaccine at risk, which means we'll be investigating considerable resources in developing doses even before we know any given candidate or candidates work. I must warn that there's also the possibility of negative consequences, where certain vaccines can actually enhance the negative effect of the infection. The big unknown is efficacy. Will it be present or absent, and how durable will it be? And finally, I want to mention the NIH has launched a public-private partnership called Accelerating COVID-19 Therapeutic Interventions and Vaccines. The purpose of that is to prioritize and accelerate clinical evaluation of therapeutic candidates with near-term potential. Hopefully, our research efforts, together with the other public health efforts, will get us quickly to an end to this terrible ordeal that we are all going through. Thank you very much. Happy to answer questions later.
Thank you, Dr. Fauci. Dr. Redfield, welcome.
Good morning, Chairman Alexander and Ranking Member Murray and members of the committee. Our nation is confronting the most serious public health crisis in more than a century. Yet we're not defenseless. We have powerful tools to fight this enemy. We have tried and true effective public health interventions, such as early case identification, isolation, and contact tracing, combined with important mitigation strategies. CDC's Emergency Operations Center is supporting state, tribal, local, and territorial public health partners in building core capabilities, particularly workforce, laboratory, and data and predictive analytics. Epidemiologists are conducting surveillance for COVID-19 as well as conducting health system surveillance. Community mitigation teams are providing guidance on infection control and contact tracing. And our laboratory experts are performing serological testing to better define the extent of asymptomatic populations. As local leadership makes decisions to reopen, they'll require varying degrees of federal support. Each location will be different and will face unique circumstances. CDC has conducted a state-by-state assessment of public health testing capacity and contact tracing capacity, as well as surge plans. CDC is providing technical assistance and funding to the states provided through the Supplemental CARES Act and the Paycheck Protection Program and Healthcare Enhancement Act. We're working directly with the state public health leaders to define their needs for testing and testing devices, supplies, and manpower, surveillance, data collection and reporting, contact tracing, infection control, and outbreak investigation. I want to spend a moment to focus on several key elements. First, testing. Rapid, extensive, and widely available timely testing is essential for reopening America. CDC's role in testing continues to support diagnosis and contact tracing, surveillance, and outbreak. And we work with the public health partners to define their particular testing strategy for their jurisdiction. Admiral Giroir will address the testing components of the response in greater detail. Contact tracing. Increasing state, tribal, local, and territorial contact tracing capacity is critical. It's a critical part to stop the chains of transmission and prevent the occurrence of sustained community transmission. CDC's role is to provide technical training, assistance, and support to the states as they hire and build a workforce necessary to be fully prepared to effectively respond to the public health challenges posed by the ongoing COVID pandemic. This will be an expansive effort. Surveillance. Our nation's surveillance program is built on a combination of systems, including existing syndromic, influenza, and respiratory viral disease surveillance systems that have been combined with commercial and research lab platforms and our case reporting form system. CDC is adapting these and optimizing it to have a surveillance system in response to COVID-19. Importantly, in light of the significant occurrence of asymptomatic infection, the surveillance for asymptomatic infection becomes an important public health tool for early case identification. CDC is working with each public health jurisdiction to develop a prospective surveillance program to include active surveillance among those that are most vulnerable, such as individuals in long-term care facilities, inner-city clinics, and homeless shelters. We need to rebuild our nation's public health infrastructure. Data and data analytics, public health laboratory resilience, and our nation's public health workforce. Now's the time to put it in place for the generations to come, not only for the public health system that our nation needs, but for the public health system that our nation deserves. Before I close, I want to recognize the tireless commitment of the dedicated CDC staff who've deployed to every corner of this nation to fight COVID-19. More than 4,000 employees have deployed here and globally. Science and data continue with technical expertise and public service to be the backbone of CDC's contributions to the U.S. response. I extend my serious gratitude to the healthcare workers in the front lines, as well as their family, and the essential emergency personnel, as well as the American people, to say thank you for adhering to the stay-at-home guidelines and protecting the most vulnerable. It's important to emphasize that we're not out of the woods yet. The battle contends and we must, but we are more prepared. We need to stay vigilant with social distancing. It remains an imperative. We are a resilient nation, and I am confident that we will emerge from this pandemic stronger together. Thank you.
Thank you, Dr. Redfield. Admiral, welcome.
Here to provide you with an update on the nation's progress in testing for COVID-19. On March 12th, Secretary Azar requested that I lead the COVID-19 testing efforts within HHS, including oversight and coordination of the FDA and CDC with regard to testing. Since then, the nation has performed more than 9 million COVID-19 tests, a number far greater than any other country and double the per capita tests performed to date in South Korea. To reach this point, we implemented a phased approach to meet testing needs during mitigation and now during phase 1 reopening of America. Beginning March 20th, we pioneered 41 community-based drive-through testing sites in locations prioritized by the CDC. These sites have been a profound success, testing over 167,000 high-risk individuals and demonstrating a prototype that is being duplicated multifold in nearly every state. Next, the administration leveraged trusted retailers, including CVS, Rite Aid, Walgreens, Walmart, Kroger, and Health Mart, who are now providing testing at 240 locations in 33 states, 69% of which are in communities with moderate to high social vulnerability. To meet the need for collection supplies, like swabs and media tubes, we first secured the global supply chain through a military air bridge. We worked directly with manufacturers to increase domestic production. We collaborated with the private sector and the FDA to validate multiple swab and media types that vastly expanded supplies while minimizing the need for PPE. Finally, we used Title III of the Defense Production Act to further invest in domestic manufacturing to prepare us for reopening. To support the need for surveillance testing during reopening, on April 27th, we issued a new testing framework that also prioritized testing for persons without symptoms who are prioritized by health departments or clinicians for any reason, including screening of asymptomatic individuals according to state and local plans. Next, our federal multidisciplinary team conducted multiple calls with leadership from each state to set state-specific testing objectives. Collectively, states and territories established an overall goal to perform 12.9 million tests over the next 4 weeks. The federal government is able to and will support the achievement of this goal. Specifically, the federal government is shipping to states 12.9 million swabs and over 9.7 million tubes of media in May alone. Last month, we also detailed the location and capacity of every lab machine in every state that could potentially run COVID-19 assays, and our team has worked with test suppliers to match reagents to these machines. Looking forward, between now and the end of 2020, the federal government will procure over 135 million swabs and 132 million tubes of media and distribute these to states as requested to supplement the now robust commercial supply. We anticipate marked increases in current tests, as well as a dramatic expansion of new point-of-care tests, like the first-in-class Quidel antigen test authorized by the FDA just last Friday. Quidel anticipates being able to distribute 300,000 tests per day within just a few weeks. So by September, taking every aspect of development, authorization, manufacturing, and supply chain into consideration, we project that our nation will be capable of performing at least 40 to 50 million tests per month if needed at that time. And if new technologies are authorized, like whole genome sequencing approaches or any novel solutions uncovered by NIH's